Hello and thank you for watching this video series on engaging primary care in opioid process improvement. This video covers a true patient story and provides some context for the impact that primary care can have on the opioid crisis.
So let's put a face to these patients and note that this is based on a true story that actually happened in Alberta. Let's meet Phil. He's a 50-year-old self-employed plumber who's been struggling with degenerative arthritis in his knee. He's a heavy smoker and self-reports moderate drinking. He's been trying to put off the knee replacement surgery for as long as possible, but his knee is becoming a major issue for work, plus he really wants to be able to dance at his daughter's wedding this coming summer. He's been referred to a local orthopedic surgery clinic for knee replacement and received a surgical date, but the family physician office has not been made aware.
So Phil has his knee surgery. He is discharged on the second day with a few Tylenol 3s and anti-inflammatory pills. He's also given a booklet with instructions for exercises and self-management. He has a follow-up appointment booked in 2 weeks with the nurse. But the T3s don't do much to help with his pain. He struggles to hang on, knowing he has an appointment with the nurse coming up. At that 2-week follow-up appointment, Phil sees the RN at the surgery clinic, who removes his staples, assesses his knee, and advises him to see his family doctor to talk about pain control. Shortly after, Phil sees his cousin, who offers him some leftover Percocet that he had for oral surgery. The Percocet work much better for Phil, and he takes them at the maximum dose described on the label, 2 pills every 4 hours. Before he can see his family doctor, he has to fly across the country to his childhood hometown to attend a funeral. While there, he runs out of the Percocet that his cousin gave him. But one of Phil's old friends connects him with a guy who hooks him up with some illicit Percocet to get him through. Unfortunately, those Percocet pills were laced with fentanyl, and Phil accidentally overdosed. When Phil's family doctor receives the notice that Phil has died due to an opioid overdose, she is completely shocked and bewildered.
We know in primary care that there can be many competing priorities, and it's difficult to divert time and resources to supporting a small group of patients. We also know that some family practices may only have a handful of patients who are currently taking opioids.
However, when we compare the number of deaths in the province that are opioid related compared to those who died of influenza, we see a huge discrepancy. There were 701 deaths due to opioids compared to 54 due to influenza, and we put a lot of resources into influenza prevention and management each year.
Additionally, we can look at the numbers not just in terms of deaths, but in potential years of life lost. When you see it's a dramatic difference of over 30,000 potential years of life lost due to opioid-related deaths compared to just under 600 potential years of life lost due to influenza deaths. So if we applied the same effort and focus that we do on influenza to opioids, imagine the impact we could have.
So far, we've focused on the patients who have died because of opioids. However, we know that there are many people living with opioid use. Specifically, there are 1/3 of Alberta patients who report that they or another member of their household have spoken to a physician within the past year about using an opioid to manage pain. 1/4 of Alberta patients report that someone in their household has received an opioid prescription within the last year. 51% reported that a second prescription was required for their condition, and 1/3 did not finish the entire first prescription. That 1/3 of prescriptions that go unfinished have the potential to cause additional harm should they be lent out, in the case of Phil, or if discovered or consumed by someone who is opioid naive, like a teenager.
The evidence tells us that primary care is part of the solution in terms of preventing opioid-related deaths and supporting those who are living with opioids. The peer group has found that opioid agonist therapy rates are higher when they are introduced in primary care as opposed to specialty care. Specifically, an additional 1 in 6 patients will be retained on their therapy. Also, patients are more satisfied when they are treated in their medical homes as opposed to in specialty care.
As of this recording, significant improvement has been made in both the number of PCN providers prescribing opioid agonist therapy, or OAT, and the number of new patients who are receiving OAT.
As mentioned before, practice facilitators do not need to be an opioid content expert. Rather, PFs can support physicians and teams with process improvement that will help to improve the patient's experience, be able to identify patients taking opioids on a panel, optimize care management and prescribing, and help to coordinate the care within the medical home and the health neighborhood. On the website, you'll find a guiding principles document that outlines what we've covered so far today. It also includes language that may help you when you're engaging teams.
In closing, we want to take a look at a different outcome for Phil. Had his team been supported with process improvements that would have allowed them to stay connected about his care? Before his surgery, Phil's family doctor can meet with him to do some assessments. Phil has a higher risk of opioid use disorder, so she confers with his surgeon about a plan. Phil has his surgery and is discharged as before, only this time a discharge summary is sent to the family doctor. As previously, Phil experiences uncontrolled pain. However, his family doctor's nurse calls to check up on him as per their clinic protocol. This time, he sees his family doctor and they decide to use a controlled dose of Percocet with a 2-week plan to taper off. His doctor sends a note to the orthopedic surgery team to keep them up to date. When Phil sees the RN for his 2-week post-op appointment, this time they have an in-depth discussion about non-prescription options for managing pain. When Phil finds out he needs to fly across the country for the funeral, he contacts his family doctor. They have a brief telephone discussion and come up with a contingency plan in case the pain gets worse. In this scenario, Phil is able to work with his care team to make sure that his knee surgery goes well and his life goes on. And ultimately, he's able to dance with his daughter at her wedding that summer.
So that's it for the end of our video series on engaging primary care. We now hope that you can reflect on some of these questions. We'd be curious to know what surprised you about the Alberta opioid crisis, and what didn't surprise you about the Alberta opioid crisis. What were your key takeaway messages from these presentations? As a practice facilitator or a physician champion, how might you use this information with teams? What do you still need to know or know more about? And do you have any thoughts? Thanks again for listening.